We're going to talk about ocular and systemic conditions with infantile nystagmus or nystagmus in infancy.
Yeah, I'm going to. I intend to go over my evaluation protocol of the patient who presents with me with infantile nystagmus. And I'd like to start off by saying I agree completely with Lou that there's probably one fundamental underlying mechanism in the brainstem that underlies infantile nystagmus. However, there are many. It can be isolated or associated with visual sensory disorders, and I need a conceptual framework in which to place the patient so I can do the proper studies and guide them in terms of their expected visual function. So I would say that in my practice, and I do eye movement recordings, and on almost every patient I evaluate, that 80 to 90% of the people that I see with INS have an associated visual sensory defect. So my exam is catered to evaluating the visual sensory system first before I proceed to eye movement recordings. How do I advance my slide? Oh.
There should be an arrow at the bottom.
An arrow?
Yep.
Okay, just a minute.
Mark, does he have privileges?
Arrows.
There you go.
Okay. So my evaluation always begins with visual acuity. Let me go back to the... I'm sorry. So why did I get... Can we go back
Mark,
to the
originals?
originals?
Unplay it. Undo the play.
I'm not hitting anything, and it's... there, okay. So which button should I... Okay.
So, sorry, we're going to remove that play button so it won't confuse you. Just those arrows at the bottom left corner.
Okay, why don't we go to the next slide, please? Next slide. So my evaluation, and I primarily see infants. So we begin, and this is a teller acuity card, and this is a patient who starts out with normal vision. Now, if they have normal vision, that's consistent with isolated INS. If they have subnormal vision, then I begin to activate my sequence of evaluation for the patient for an underlying visual sensory disorder. And here's I don't know what's going on with that. Here's a patient. So the eye exam becomes the first. So becomes the first critical element. Do I have a media opacity, such as demonstrated here with the cataract, or do I have? It's not advanced.
You know, we can advance the slides for you if it's a problem.
Yeah, why don't you advance it for me? I don't know what's going on here on my laptop. And here's a patient with aniridia. So this is really what the ophthalmologist in practice encounters, and this is what you're going to look for. So I'm going to look for cataract. I'm going to look for aniridia. Advance, please.
We've done that.
Or in this child who comes in with obviously subnormal visual orienting behavior and a vision, a very low vision, perhaps they can see the teller acuity card and having a 2600 acuity, I'm thinking about something more in the fundus. Advance, please. Or the back of the eye. And here you have severe bilateral optic nerve hypoplasia. And the biggest problem that I encounter with optic nerve abnormalities in infants is if you look with an indirect ophthalmoscope, you'll miss the anatomic deficit. You have to, even though it's painful, you have to look with a direct ophthalmoscope, because you'll miss the fact that this individual here has a 300 or 400 micron optic nerve, but what you're looking at is the underlying sclera, which is the larger, whiter ring. Advance, please. And the same thing in the other eye. So this patient was completely missed. The diagnosis was missed. Next slide, please. Now, one of the other pearls when I see an infant who comes in with nystagmus is multi-directional nystagmus. So here on the upper trace, I'm showing the horizontal oscillations, and on the lower trace, I'm showing the vertical oscillations. when I see a multidirectional nystagmus, I know that I'm dealing with severe optic nerve disease or retinal disease if they have an underlying ocular basis. And sometimes you see strange things. So next slide, please. Here's a child that and I see this fairly commonly, but your evaluation has to extend beyond the eye. The previous slide, please.
Yes.
Your evaluation has to include a careful history and developmental history. And here's the child. The only red herring here was they were anemic. So because the child had anemia, that triggered the possibility of and nystagmus of osteopetrosis. And I've seen several of these patients, and if you don't, and this is not your typical infantile nystagmus patient. So if you do not pick this up, these patients go blind. So the diagnostic evaluation is critical. Next slide, please. Advance, please. And, okay, next slide, please. Okay, and here's a common one. Here's one that I see a fair amount, and that's the child who presents with infantile nystagmus and has an underlying visual pathway tumor. Here's an MRI scan which shows a large tumor centered on the chiasm. And you have to, but in this child, if you looked at the nerve with a direct ophthalmoscope, you see optic atrophy. Or maybe if you did a systemic exam, you'd see that they had a hypothalamic syndrome, or they have other features of pan-endocrine deficiency. So the evaluation is not only of the child with INS is not only an eye exam, it's a systemic and developmental evaluation. Next slide, please. Now, the most common one that we see is albinism. And here's the typical transillumination defects. Next slide. And here's the typical fundus. And like last week, I saw a patient, black hair and relatively dark skin, but this is the fundus. No one wanted to make a diagnosis of albinism. Albinism is an eye disease. It's a genetic disease of skin, hair, and eye. And you may not have much skin or hair involvement, and it may be primarily eye involvement. And I would say albinism is one of the most difficult diagnoses to make, specifically subtle cases of albinism. Next slide. Here you see the typical blonde fundus and the macular hypoplasia. Now, the OCT is revolutionized in our practice to diagnose. Here's an OCT of a patient with albinism where you can see there's a normal cone density peak, but there's a loss in the length of the outer segments, and there's persistence of the inner layers of the retina. And Dr. Proudlock's group have well documented the various grades of albinism. Subtle albinism is very frequently missed. In every patient that I have with infantile nystagmus, at some point I get an OCT to rule out albinism, just to make sure I'm not missing the diagnosis. Next, advance, please. Now, what about the child that comes in that has a normal fundus? This is enigmatic. What am I dealing with? Next, advance, please. So there's no obvious cause. So here's a child that comes in with a conjugate horizontal pendular nystagmus, looks like any other form of INS, again echoing what Dr. Deloso said. But the diagnosis is made, the proper diagnosis is made on the basis, you can't make it on the eye movement. Next, advance, please. Color. Well, in an older child, you may be able to do a color discrimination test and know that this child has achromatopsia, or it may be very apparent when you turn the lights on in the room that they squint their eye because they're so light sensitive, because there's abnormal intrusion of rod responses under light adapted conditions. Next slide, please. Advance. And here's an OCT that shows the cystic lucency, the typical cystic lucency in the fovea of patients with achromatopsia. That is, the patient who lacks rods and cones who lacks cone photoreceptor function has normal rod photoreceptor function. Advance, please. I don't remember what I'm showing here. Next, sorry, guys. Advance. And here's just, again, to emphasize, that was a patient with Leber's congenital amaurosis. So what I'm demonstrating here is the upper tray shows a horizontal nystagmus and the lower tray shows a vertical nystagmus, multi-directional nystagmus. You got to think about underlying optic nerve abnormalities and retinal disease. Next, I think that's about it, guys. And the diagnosis of there's a whole host of retinal dystrophies, early onset cone rod dystrophies, Leber's congenital amaurosis, and you have to have an ERG set up. So you have to have OCT. You have to be able to do an ERG. You have to be able to do color vision discrimination testing before you proceed to eye movement recordings. I do that last in my diagnostic sequence. And here we show the typical patient with a Leber's congenital amaurosis in whom there's severe reduction or extinction of both the photopic or cone-mediated response and the scotopic or rod-mediated response. Advance, please. I think I'm done, guys.
Okay.
Next slide, please. I don't think there's anything. Last but not least, this is a little. I evaluate a lot of kids with metabolic disorders, so I made a little list because you can't remember this. So I made myself a list of all the metabolic disorders that we can see with infantile nystagmus that I've encountered in my practice, and the maple syrup urine disease, the Kahneman's disease. I see lots of these transcobalamin defects that present because of newborn screening. We're seeing lots of kids now that come in with infantile nystagmus, and they put them on treatment, it goes away. Or the carbohydrate glycoprotein deficiency disorders or glycosylation disorders. They come in, and but we don't think about them. So you have to think out of the box about these other underlying systemic disease. It's not common, but the peroxisomal disorders, Zellweger's. You have to know: do I need to look for stippled epiphyses when I'm evaluating this patient with a peroxisomal disorder, or do I feel their belly for hepatosplenomegaly? It's a very complex evaluation, and I think I'll end it at that. Thank you very much.
Thank you very much. We actually, that was a fantastic talk, and we actually have a few questions. Is it okay, Rich, if we hit a couple of them?
Sure.
I will just read the questions from the audience and direct you to how we go about doing. So, first of all, Farouk Orge, my good friend Farouk from my days at Rainbow. How are you, Farouk? It's good to hear from you. What color vision test is the panel using? Ishihara versus HRR?
I use the D15, which is the CAPS. We use that as part of our official color when we do color testing. I don't know if anyone else.
I use the D15 and the AOHRR. The HRR is a gross screening test. It's okay, but if you want a more definitive test to characterize the color vision defect, I go to the AOHRR or D15. They're not going to usually cooperate with the Farnsworth-Mansell 100.
Perfect. Moving on to the next.
We do.
Go ahead. Sorry.
Oh, I'm sorry. We're unique in that we do color VEPs too. So if you want to really or genetics, because we have a whole host of people who do all the opsin genes. So I have that. I can do that, but it's not relevant because it doesn't change their outcome or their therapy.
we're going to move on to the next question. And also, again, I want to remind the audience, feel free to call into the number. We'll put this number up on the screen right now. Feel free to call in if you have a particular question or comment you want to make. Don't just leave it to the faculty. We want to hear what everyone else has to say. Ruth Hamilton wants to know what the panel thoughts on head-mounted goggles versus infrared EMR equipment. Any recommendations on a particular manufacturer? Anyone want to tackle that one? Rich?
Well, the head-mounted systems, each commercially available system has its pluses and minuses, but it depends on what you want to use it for. So if you're doing infants and children, you probably don't want a head-mounted system because the babies are not going to be able to tolerate it. That's why we like the remote video. And with the new remote video systems, there's actually tolerances now. The new iLink system, not that I have any particular interest in iLink other than scientifically and clinically, has a tolerance of maybe 6 to 8 centimeters of movement because they have a head in both eyes. So I would encourage you to get one that you can use in everybody, not one that is population-based or age-related based.
I will add a few sentences. The remote camera type of recording system is also very flexible. You can set up at a different angle, let the patient turn the head, so you can measure at different gaze angle, not just fixed, like 30 degrees, the maximum you can get with the head fixed system.
Perfect. The last question is, or to comment, and you may have to interpret this, but some patients treated surgically have the same BCVA after the procedure, but do present improved reading visual acuity and improved reading speed, apart from better use of the computer without the AHP.
I answered that, or I guess.
Yeah. We want to just talk about it here. So just
it's because the therapy has improved vision to the side, so you can look over there and find the word, whereas before you couldn't. So even though the peak acuity hasn't changed, which doesn't really matter when you can hold the book close, but you have to be able to scan the lines quickly, and you can't do that if you can't see over there.
Reading requires a completely separate set of skills in addition to acuity. So you can change the font size and measure reading ability. So in someone with low vision, who you get them to their, you increase the font size to their reading ability, you can measure the same reading abilities in them. So a reading is much more complex oculomotor and neurophysiologic skill than just best corrected acuity or high spatial frequency, as Dave was alluding to. There was one thing I wanted to point out in Avery's excellent lecture, because it's a little scary sometimes to hear this. Does this mean that I have to get an MRI in every patient with INS? I don't.
I'm glad you asked that because that comes up all the time, Rich. And no, I don't. I don't do an MRI in INS because I think that's wrong because that's unless you have opsoclonus myoclonus syndrome in a young infant. But you can tell from the eye movement recording. So I always go for the eye evaluation, the visual function testing, and the eye movement test first. Right. Then if it shows opsoclonus myoclonus, then they get an MRI scan.
Okay, because in my experience, I'm telling you, in thousands of INS patients, I maybe have 1 or 2 associated brain tumors from that way. Usually I'll see the tumors first. So it's rare that I'm the one that has to make the diagnosis of a brain tumor. Having said that, if I see prechiasmal structural disease, then I will suggest an MRI or a systemic evaluation.
Well, you see optic atrophy or some other sign, or you see hypothalamic syndrome. You have other evidence.
Right. Dave, what's been your experience?
Get an MRI.
Hey, Dave, do you get MRIs on these kids?
Well, no, not routinely, but if I see a child with optic nerve hypoplasia, yeah, I'm going to be getting an MRI, even though they may have an INS waveform.
Right.
So I think that, what Avery was talking about was the associated systemic and ocular findings that go along when you see a patient with nystagmus. And the workup and Avery, I saw you showed televisual acuities at 1 to 2 months of age, where I have a little trouble at that age getting the,
Yeah, I think 2 months is the threshold, Dave.
Yeah, and then ERGs at that early age, depending upon your lab, can be very tough, and each lab has to be figure out their own norms even at that young an age.
Well, I usually delay the ERG till about 6 months, and because then the people at Philadelphia have shown that the amplitudes and latencies are almost adult-like at that age.
Yeah, I agree. That's why when you were talking about the infants, I wanted to see if we were on the same page for that.
Yeah, no, we're on the same page, Dave.
Yeah, I would delay for that as well. And so, Avery, the question I had for you is, after you've made the diagnosis of any of the associated ocular findings, from ONH to achromatopsia, now the child's got nystagmus. And I think that what Lou is talking about, and my understanding of this, is that in any of those cases, you still have the opportunity to take a child and make an impact on their visual system by affecting the nystagmus waveform, despite whatever the other associated findings are. And I was wondering what your thoughts are on that.
Well, I'm very conservative in that regard, as you know, and unless I have hard scientific evidence for optic nerve hypoplasia that I could improve their visual function, I don't recommend it. I have to have the scientific proof that I've improved their visual function, whether that be acuity, their acuity at different gaze angles. The nystagmus intense, the changing the waveform. Most of the waveform is non-foveational. It's so that changing the waveform, I'm not sure how much that's going to buy you. You only see during. I mean, Lou, he really started the systematic assessment of nystagmus when he described the foveation period. That was one of the great scientific discoveries in nystagmus. And I stick with that foveation period. If I can't improve the foveation period, and by increasing the foveation length, you may not improve their acuity. I don't find a relationship between foveation duration and acuity beyond a certain threshold.
So Avery,
improving the waveforms, it doesn't necessarily, except in patients that don't have good foveal function. Knowing the relationship between eye velocity and acuity, if someone doesn't have a good foveation, improving their waveform might buy you something in terms of visual function.
Avery, there are data, though, for what you want. I mean, we have data on optic nerve hypoplasia, on foveal hypoplasia. We have data specifically isolating out the improvement in vision and visual function with afferent system disease. There are data. It's done. I mean, it's not done in the same way as the pedic studies with thousands and thousands of patients, but there's clear data showing and consistent data showing that improvement in the nystagmus waveform after surgery improves function in patients with afferent system disease, including optic nerve hypoplasia. As a matter of fact, what Lou suggested is very important, that the ceiling or floor effect, whichever one you want to call it, with acuity is that the lower the acuity and the poorer the visual function, the greater the improvement in functions are by improving the motor system. So I would encourage you to, this is part of the resistance that we have to doing the procedure, is that we get that, exactly what you hear, is that I want to see data, but we have data. I mean, there's tons of it. It's actually now in the book. You don't even have to read the literature. You can just read the textbook, which refers to the 50 years of literature. So there is data. So I don't know why I hear this, and I'm not picking on you specifically, but I hear this from the colleagues, I just want to see data. Well, that's what we've been doing for 30 years, is collecting data. So it's out there. I don't know what to say except type it in on PubMed. Optic nerve hypoplasia, visual, just do it. It's there.
Well, I have to convince myself.
Okay, that's the difference.
that is the difference. Because the curves I showed you had achiasma and albinism, and they got just as good improvement as the people without.
Well, as you know, achiasma, we show that it can improve their acuity in achiasma.
That's a pretty bad disease.
I do have that evidence, yes. But that was a systematic study, and it showed improvement.
So I'm so torn here because this is what we want. This is the whole purpose of this. The talks are nice, but we really want everyone talking and debating and discussing. That's what makes this different than a boring lecture. But we are a half an hour behind. Did you want to make another comment before we go?
Oh, okay.
It's unimportant to most people but me. I'm glad you agree on the single cause and the associated as opposed to causal. The opposite of associated is unassociated, a much better term than idiopathic, which means we don't know what's going on. I think we do know what's going on. So unassociated is a better word. That gives you your other group.
All right.
Okay. Thanks.
Let's move on, and then we'll get into more of these discussions, I'm sure, in the future. We also have other questions.